Oh, you need to activate the screen share.
Sorry. Should be good.
Good. I guess next step. So you see my screen?
Yeah.
Sweet. Okay. So let's talk about appendicitis. So it was kind of an unexpected talk, but it's it's prepared for a long time. So let me know if you have questions at any time. Now I can actually see your faces, so it's good. So you know me all, so Lori, I work at the Jewish, and I'm going to work in Valleyfield in about an hour and 15 minutes from now. So I don't have any conflicts of interest to declare for the presentation. And in terms of the objective, today I want us to go over the 3 different techniques of finding the appendix for the diagnosis of appendicitis. Try to name some of the POCUS findings that are suggestive that your patient actually has an appendicitis. And also try to describe how do you integrate that in your practice? Because honestly, I don't do POCUS for all my patients with suspicion of appendicitis. I think it's a bit counterproductive. So when do you get your probe to try to diagnose it? Appendicitis. How do you do this? So step number 1 is, in theory, you want to get the highest frequency probe. Why? Because the appendix is a subtle structure. And with the big curvilinear probe, you might not be able to appreciate what we're looking for in terms of the findings of appendicitis. Like any other disease where patients have pain, try to use a lot of gel to give you a good window so you don't have to push super hard. So the gel will kind of help you manage the fact that you need to compress a bit. So the linear probe is actually your go-to probe if you look for the appendix. However, the reality is a little bit different. Most of our patients are actually on the other side of the spectrum, so a little bit more towards the right of the screen, where the linear probe is definitely not going to be able to, you're not going to see anything, you're just going to see the abdominal wall muscles, and then that's going to be it. So I would say that when you're looking for an appendix, use it in people that you think you might be able to find it. So those with a little bit lower BMI. Those who have, let's say, a lot of subcutaneous tissue or a lot of adipose tissue, don't lose your time there. You can try to find an alternate cause, but it's not the time for you to get your linear probe and really try to fish for that appendix. So just a word of caution. In those patients, though, if you really want to try and you're, I don't know, you're working in Wakefield and there's no way you can get a CT scan, and then that's going to make the decision for you to transfer the patient or not, and you still want to give it a go because you have time. Well, the patients with them who are a little bit, have a little bit more weight, then try to use the curvilinear probe. It's exactly the same technique. And again, generous amount of gel. The technique is very simple. Just like the small bowel obstruction, and I'm sure you guys have tried it before, you want to do what we call a graded compression. So this is the belly, and you're going to try to put some pressure. Why? Putting the pressure will basically compress the gas and remove it out of your way, so you can actually see the structures underneath. And we're going to discuss this because we need some landmarks before we start fishing, because as you know, bowel gas looks like nothing. It's just a big mess full of air. So the technique is going to be a graded compression where you want to compress the gas and you want to mow the lawn. So you're going to do some fishing, just like small bowel obstruction. Okay, so let's go into the 3 techniques I want us to discuss a little bit more in detail today. The first technique is at the landmarks, and actually that's the most reliable one. So in every patient, you're going to be able to do that one. The follow the cecum is it's more for the fellows in POCUS, but also the experts, because it takes a lot of skills to actually follow the cecum all the way down to where you think the appendix might insert. Yes, it's still a good technique to try. And then the area of maximal tenderness, my personal favorite, and I think this is something you should have in your pocket. So let's go over the landmarks technique. So the landmarks technique is super easy. You want to start in the right lower quadrant, and you're going to place your probe in transverse. So transverse is like this. You're going to find the iliac crest. So everybody, you can touch your ASIS, and you're basically going to put the probe a little bit more medial to that. And the image you're going to get you can appreciate on the screen, right under the probe marker, the green spot, is going to be your iliac crest. Once you have the iliac crest, you're going to find some other structures that might be ring a bell. The psoas muscle. So this is the psoas muscle that I can identify right here, okay? And the iliac vessels. So you're actually quite deep in the pelvis, right? You're not next to the belly button. You're a little bit lower than that. So you're going to find iliac, psoas, so iliac bone, psoas muscle, and iliac vessel. And the appendix will often lie in that area, right above the psoas, right next to the iliac vessels. Honestly, I've never seen an appendix that was actually lying on the other side, so medially to the iliac vessels. It's usually going to lie laterally or just above. And I have a baby cat trying to jump on me. Okay, good, stay down. Yes, so the appendix is actually going to be in that area. That's why, if you remember your medical school, we do the psoas sign and we do, the leg crossed, and then you're trying to elicit pain on extension. That's because the appendix is supposed to lie right in that psoas. So in theory, when you contract that muscle, you're going to irritate the appendix and create that psoas sign. Now it makes all sense, right? Remember the anatomy. The problem with the landmark is that the appendix can lie anywhere. So that's a beautiful picture of a cecum. So that is actually the cecum all the way down. And then the appendix can take off anywhere. It can take up a little bit more superior, inferior, lateral, medial, and then retrocecal, where there's no way you're going to be able to find it, honestly, with ultrasound. So this is why you need some other techniques. And this is where the follow the cecum technique comes in. So in theory, if you really follow the cecum very well, all the way down to its distal end, you're going to be able to find the appendix. The way you're going to do that, you're going to start in the right upper quadrant with your probe in longitudinal, just like you do a FAST exam. And then what you're going to do, you're going to slowly go down until you find that dirty gas. The dirt, when you see small bowel, the small bowel has this nice linear pattern of air. It looks like A-line, just like you would see with when you do a pneumothorax evaluation. So clean pattern of gas. When you get to the colon or the large bowel, it's dirty. It looks like a mess, just like on the screen. It's like speckles and gray and black and white. This is large bowel. So you're going to find the large bowel, similarly to when you do your paracolic gutter scan for small bowel obstruction, and you're going to move caudally. So you're going to move down really slowly, always following that dirty gas until all of a sudden the dirty gas is kind of tapering down in a round shape. And this is where you're actually going to be. So you're going to see dirty gas, dirty gas, dirty gas, dirty gas. Oh, it looks like it's turning. And then all of a sudden it's not dirty gas anymore, because here you're going to follow a lot of loops of small bowel. When you see that, you go back up a little bit, and this is where you start scanning a little bit more like this. You're going to go mow the lawn until you find that little taper zone where you're going to see dirty gas, and then something that looks tubular, that is the appendix. Okay, so you start in the right upper quadrant, you move down, probe in longitudinal, you identify the large bowel, which is dirty gas. You follow the bowel down until you see that tapering, and then you try to find the appendix. This is an example. So we followed this. So this is cecum. It was dirty gas. You can still see that there's a lot of shadow, and whoop, all of a sudden, you see that little tubular structure that is a blind pouch, which is something we're going to talk a bit later. And you can see underneath, there's actually the psoas muscle. So anatomically, it still makes sense, but you're kind of using a different technique to find it. And again, I know that sounds like, okay, that is a bit complex. I agree. It's actually something you really need to practice and have very good dexterity to really be able to follow this. Yet it's a good tool in your pocket. Let's talk about my personal favorite. So I love to do this. I say, okay, I want you to take one finger, show me where the most pain is. And then you ask them to point at the area of maximal tenderness. And this is where you put your probe. And honestly, very often you're going to actually find something. And this is where you look for the appendix. Okay, so let's talk about what does a normal appendix look like. Okay, so we just talked about the dirty bowel, dirty gas. That's actually what it looks like. I don't know if you can appreciate, but it's like speckles, right? It doesn't look like linear A-line pattern. This is the cecum. So the cecum comes in and then tapers into a little mini pouch right here. That is the appendix. And again, you can appreciate that this is the iliac vein. So anatomically, it's exactly where you would expect to find it. And you can actually use both techniques here. So follow the cecum and the landmark technique. This is a normal appendix, so it's very thin. And I'm going to stop here just to describe where do you measure when you decide to measure for appendicitis. So I'm going to bring you back again to Anatomy 101 of the bowel. You can appreciate here that there's an there's an inner dark layer. That is the mucosa of the bowel. And then you have a brighter layer right above it. That is the submucosa, and it's usually bright. And then right above this, you have the muscularis propria and the serosa. They're tightly together. So the appendix has 3 layers, or the bowel has 3 layers. And you really have to measure from outer dark wall to outer dark wall. Don't do the mistakes of measuring inside, because this is the whole structure. So the darker layer is part of your appendix calculation and part of your appendix itself. Very good. So this is a normal appendix, sorry. This is another video. This is actually a video of another normal appendix. Again, look at that dirty gas here. Great example. Speckled, there's a lot of artifact, and it tapers down into a very nice little thin tubular structure right above the iliac vessels. Very nice. Normal appendix. Another example, and now we can actually appreciate, I don't know if you can see, but the iliac vessels are now in longitudinal, right? Instead of being in transverse, now they're tubular, so we know that we're in longitudinal. And at that point here, the appendix is going to look like a circle. And remember that image of the cecum in different position of the appendix, it's not always going to look round. Sometimes it's going to be a tube, sometimes it's going to be round, depending on where you catch it and how it's positioned. So normal appendix, that is really subtle though. Okay, what does an appendicitis look like? An appendicitis look like the appendix we just saw, but they look thicker, right? Look how we can appreciate now that the layers, especially the inner mucosa, is actually quite thick, but also the submucosa. And this is where you would basically measure it. So the outer dark wall to the other dark wall. This is example of appendicitis where it's thick. And it's clearly different from the others that we just saw. And that's the same appendicitis, but in transverse, where you catch, it almost looks like a little target sign, right? And we can see that there's actually some infiltration of the fat surrounding it, but that's a little bit more advanced. And again, appreciate the iliac vessels. So here, if you ask the patient,
So I was just going to ask, so can you point out with your mouse where you would measure from on the specific image?
Yes. So let me just freeze it. Good. So I'm going to measure from here all the way down to here.
Okay, thanks.
Or like from here to here. It's quite thick. And that's tough again, because there's a lot of fat stranding around it. But this is clearly enlarged. And if I were to take the measure now, I can't measure, but it's almost like a centimeter. And we're actually coming to the criteria. Oh, what a great way to introduce this. So what are the criteria for you to diagnose an appendicitis? Criteria number 1, it has to be a blind pouch. Don't get fooled, because in the area of the right lower quadrant, you get tons of small bowel loops. Small bowel loops, they will look tubular structure, quite thin, but they won't have a blind pouch. They won't end. They keep going, right? There's tons of it. So you really have to be patient to really try to see if it really is a blind pouch. Once you realize that it really looks like it's a blind pouch, there's no continuum. The other criteria in size is actually to have it more than 6 millimeters in diameter. So it has to be a little bit thick. Most of them, they're going to be about a centimeter. It's going to be quite obvious. And the subtle ones, and I'm sure you've seen on a CT scan where they mention, well, the tip of the appendix is actually 7 millimeters, but the rest looks less than 6. So it's indeterminate. So they use the same criteria for the CT scan. So more than 6 millimeters is what you're looking for in a blind pouch, and has to be non-compressible. Because sometimes it will actually be a little bit thick. Let's say you have an ileitis and you actually think it's a blind pouch, but it's not. Or you're like, oh, wow, it's more than 6 millimeters, but then it's going to be compressible. An ileitis is just going to be thickened bowel, but then when you press on it, it's actually going to collapse. The appendix won't collapse, so it's non-compressible. Again, similar to the small bowel obstruction technique. So blind pouch, more than 6 millimeters in diameter, non-compressible, and there will be no peristalsis. That's the also important point to distinguish between a loop of small bowel. You have to be patient, you compress, you stay there, and you look. And if what you thought was the appendix starts moving and doing some peristalsis movement, well, that's not the appendix. The appendix doesn't do peristalsis. It's actually just a fixed structure, not like the small bowel. Okay. So this is an example of a blind pouch, right? You're going to scan it, and you really realize by scanning it from side to side, up and down, that it really is that blind pouch. You're going to measure it, again, from the dark outer wall to the dark outer wall, and that is definitely more than, it's actually 7 millimeters. So this one is actually subtle, but you know clinically that's an appendicitis. And again, outer wall to outer wall, the dark to the dark. And it has to be non-compressible. So here I am, look at this, compressing, and I'm not letting go. I'm being very, very patient, and I'm going to compress, and I'm going to look, is there peristalsis? That's the structure, sorry. I'm pointing with my finger, you know, right there. So this is the appendix or appendicitis, and I'm compressing, and I see that there's absolutely no peristalsis. Again, realize this is the iliac bone. You're going to have your psoas here, and your iliac vessels are in that area because you can see some pulsation right there. Pulsation. So you know that there's some iliac vessels in that area. So beautiful example of appendicitis, non-compressible. And again, be patient. This is actually something that I did at the children, just starting, I was like being junior, I don't even know the date, but that is a big appendicitis right there. And there's no peristalsis. I'm really looking, and you can see here, these are small bowel loops up there. It's a little bit different, right? And you see that there's some air in it, and if you were to wait a bit, you would see that they are moving while this structure is not, and that's the appendix. So these are the criteria. Blind pouch, again, I remind them, blind pouch, more than 6 millimeters in diameter, non-compressible, and no peristalsis. But there's some other findings that sometimes will kind of help you to really confirm that this is what it is. I love this. So the ring of fire. So if you put some Doppler flow, so you put on your color, you know, the color flow, you just take the box right above what you think could be the appendix or appendicitis, and then this is what you're looking at. So you can see how there's a ring of fire. So your submucosa is actually lighting up, just like a ring of fire. That is a sign of appendicitis. It's a supportive sign. It's not a diagnostic criteria sign. Other signs, sometimes you're going to be able to appreciate a very thickened appendix, right? You can see how the wall looks angry. And here you have the appendiculate, just like the gallbladder stone that you can appreciate in the gallstone in the gallbladder. Here you have a little stone or a little appendiculate in the appendix that's definitely causing the obstruction and the pathology, giving you that shadow. Another sign suggestive of appendicitis. Sometimes also I didn't include it here, but you're going to have in the right lower quadrant some free fluid, just a tiny bit of free fluid next to your iliac vessels in that area. And that is usually a supportive sign of this, but it's not perfect because sometimes you'll get this because you have, I don't know, some other pathology that we're actually going to discuss right now. So let's integrate it together. Okay, so you're working in emerge shift and then you have someone coming in with right lower quadrant pain. You put your probe at the X area of maximal tenderness, and what do we see here? That's actually quite easy because I showed that picture a few times. So it looks like an appendix, an inflamed appendix, and you think it's appendicitis. You stop, you do your measurement, it looks angry, it's non-compressible, blind pouch, no peristalsis, it's definitely more than 6 millimeters, you're done. This is appendicitis. But then what do you do with this? So depending on where you work, very rarely a surgeon will say, I believe you, let's bring that patient to OR. It will happen in kids. It will happen in smaller centers when you show them your image and you have a perfect thing. And it's usually when you have a male patient. Because in female patients, there are other things that could show you that looks like this. Sometimes hydrosalpingo skin looks like this, some in ovarian pathology. And most people would want to have a bit more of a formal thing. But for me, as I always say with focus, I will kind of put that patient, I remove my cognitive load of diagnosis from that patient. I know what she has or what he has. I can pretty much certify that this person has an appendicitis. So I'm going to give him some analgesia. I'm going to wait for the formal ultrasound in the morning, or the radiology perform ultrasound, should I say, in the morning. And I'm going to just put them in PO. So right away, he's kind of in the box. For me, I don't need to pursue any advanced imaging right now. I know the disposition of that patient. Yeah, so depending on where you work, it's going to be a little bit different in terms of the management. Another patient, white lower quadrant pain, a little bit more adipose tissue, as you can appreciate on there, up there. And sorry, my screen, let's say my screen is flipped. So you're putting your probe and then you're looking for those iliac vessels and you're not sure of the anatomy. And then you notice it. So this is bladder, if I can remind you. And here I'm trying to look at the uterus, but then I have this structure right here. So what can it be? Could be pregnancy, right? That's one of the things that is in your differential, right lower quadrant pain. Could that be an ectopic? So let's say that's the right lower quadrant. Not sure why it's flipped. Yeah, so that could be an ectopic pregnancy. This is actually a good example. I actually thought that was an ectopic pregnancy, but that's not. That's actually an ovarian cyst, so a hemorrhagic ovarian cyst. And that's just to illustrate that sometimes when you get the probe and you think, okay, I'm going to look for the appendix, I have some time. Well, sometimes it's going to pay off because you're going to find an alternate diagnosis. All of a sudden, you're not going to scan that patient. You pretty much know what she has. You probably know, and you're going to get a pelvic ultrasound in an elective way. Maybe a day later, you can send her home or monitor her if you find some free fluid and the hemoglobin is dropping. So all of a sudden, focus just change your management for that patient. So in your differential, sometimes you'll find something else. Hemorrhagic ovarian cyst is the example here. And then sometimes you'll find this, right? You're like, uh-oh, this is a live intrauterine pregnancy where you have your bladder, your uterus, and a little baby with a fetal heart rate. That's a nice surprise. Live IUP. And sometimes as you're doing your graded compression in the right lower groin, you're going to find this. And I don't think we did the presentation this year yet, and I'm pretty sure we're going to be talking about this. But this is a great example of small bowel obstruction. So this is a dilated loop of small bowel that is non-compressible with no peristalsis. So although it looks like an appendix, it's actually quite bigger. It's about 2 centimeters, you can appreciate right here. And sometimes that's what you're going to find. And then the patient tells you, oh, it's true, I've had 2 surgeries before, gallbladder and appendix, or gallbladder and something else. And then here you go with your diagnosis of small bowel obstruction, not expecting to find it, but then now you know, and your cognitive load, again, is out of your mind. You kind of have your diagnosis for that patient. And that's pretty much it. So some take-home messages for you today in terms of appendix. I know it can look difficult. This is a bit more of an advanced topic, okay? But it's still cool to know about it, and still cool that one day you will try it and you'll find the appendix and you'll be so happy, and it's gonna make you feel great. I think focus for appendicitis is feasible and useful. You have to have an approach. So remember those 3 techniques that we talk about. And remember that you want to try to use it in people when you think it's going to make a difference, right? Not the one you're going to be looking for like 15 minutes. You don't have that much time. The other thing is think of it as just part of an evaluation extension of your physical examination. Again, with a question. Always you have to have a question for your ultrasound. Pain in the right lower quadrant, let's look to see if there's an appendix. And then sometimes you will find an alternate diagnosis. That's going to be very useful for you in your practice and your flow. I want you all to try it on your next patient with suspicion of appendicitis, okay? I think it's really good, and it's something that you can do. Remember those little tips, and I can try to send you, I have a little summary of all the criteria that you can look at in case you don't really remember them, because we don't do it as commonly as some other focus indications. So I'm gonna take any questions you might have. We're on time. I'm gonna stop sharing my screen so I can see you. Are you guys still there? It's always my biggest nightmare. You know, you're just talking for 20 minutes and then you're disconnected offline.
Definitely still here. Can you just show, like, you were kind of doing it with your hand, but so just so I understand the scanning technique, can you just show with your hand what you were doing, like where you usually start if you're not doing the, like where the pain is the worst?
So you mean the cecum?
Yeah, so you start all the way up at the top and then you sit down?
So you basically take your probe, and now you're going to see my joggings. Yes, I'm wearing joggings. So you basically take your probe right here, and you're going to just go down like this, follow the cecum all the way down to the iliac bone. And this is usually where your cecum is really going to kind of become round a little bit, and this is where your appendix is supposed to take off anatomically. So you do like a fast. So I don't even have anything. Oh yeah, my phone. So that's the probe. You take the probe and you're going to go just like a fast. So right here, where in the right upper quadrant, you're going to slowly slide down like this until you hit about the iliac crest. And this is really where it's going to taper and become. And honestly, you really have to do it yourself. You're really going to see that you're following the dirty gas, and all of a sudden you're like, hey, it's not dirty gas anymore. You're going to see the iliac crest. You're going to see some other structure. And this is where, once you're down, so you're like, okay, oh, I'm touching the iliac crest. There's some dirty gas that I can appreciate here. And you're going to do up and down like this and you're going to move down like this, and you're going to start seeing some other definition. So the small bowel is going to kick in. The ileum is there, right? This is the cecum becomes the ileum becomes the cecum, and this is the ileocecal area. This is where your appendix is in theory. But you have to kind of try it for yourself to really understand it. If you don't find your appendix on a thin person, that is a great question, Rebecca. So I don't know why. I have to be politically correct, right? Because this is recorded. But in academic centers, there's this mentality of just sending everyone to CT, and sending everyone to CT with oral contrast for appendicitis. And if you look at the literature, and Mustafa, I know, looked at this, there's a lot of centers who don't do drinking, so oral contrast for many of the bowel pathologies. And you can imagine when you have a small bowel obstruction that you're not going to be able to drink much to coat your bowel, whatever. So there's this big mentality of CT in academic centers. Well, let's say I work in Valleyfield, you're not going to scan a patient first. Most of the thin patients, you're just going to send them for an ultrasound. Let's say I don't find it, I'm going to request the ultrasound for the morning by the radiologist. And that's going to be the step. And that's the step that we were always taught in textbooks. We're really moving towards the CT. I find as a Jewish, or when I was a resident in other places. Well, remember in PEDS, you would really never really start with the CT first, right? Because it's radiation, it's a more expensive test. There's possibility of allergies to contrast. So this is something you want to try to avoid. And I would say that it's still completely okay to request an ultrasound in a thin person. But again, remember that an obese patient, the radiologist is going to struggle as much as you to try to find the appendix. So that might be the indication where you would move to something else, such as a CT scan. But it's a good question, and I would still argue that the ultrasound has its place in the diagnosis of appendicitis. Can you comment on retrocecal appendix and pokes? Oh, so tough, really, really tough. This is where your follow the cecum technique works kind of well, because sometimes you will be able to appreciate where it's coming. But then again, if it's lying behind the cecum, the only thing you're gonna have is dirty gas, and then you're really gonna blind your view of the appendix because of that dirty gas. So this is one of the pitfalls of the POCUS for appendicitis, is that retrocecal is going to be really, really tough.